Thank you, everyone, for joining us for this presentation on funding universal health care in the Commonwealth of Massachusetts with An Cote LaRue. My name is Lynn Newkirk. I am the MassCare Board Treasurer, and I'm a co-host with John Weissman, a MassCare Board member, and also the president of Universal Healthcare Education Fund, our sister organization. Kimberly Connors, MassCare's Executive Director, is handling our tech this evening, along with interns Polly Polyansky and Kate Edenson, a couple BU interns from the School of Public Health. To begin, I just want to give a little bit of background on the study on this report. This updated analysis was based on methodology used by Dr. Gerald Friedman, a professor of economics at UMass Amherst and a longtime expert in the area of single-payer healthcare. Dr. Friedman has had some health issues and was not able to update the report himself for 2026. MassCare has been working with Dr. David Chin, an assistant professor of health policy and management also at UMass Amherst. Dr. Chin introduced us to An Cote LaRue, a graduate of UMass Amherst, who is currently a master's student in economics in Bonn, Germany, University of Bonn in Bonn, Germany, and is planning to go on for his PhD. Auden, in collaboration with Dr. Friedman, prepared the actual update of the analysis and updated the report to reflect the current circumstances of our healthcare system. I'm pleased to introduce Auden. And Auden, you can take it over from now.
Hi, everybody. My name is Auden. I will go ahead and share my screen for the presentation that I have prepared today, which is based off of the report that I have written in collaboration with Dr. Friedman, entitled Funding Universal Healthcare in the Commonwealth of Massachusetts. I don't think I have anything to add onto Lynn's introduction, so I will of myself, and so I'll go right ahead with talking about the study. And I first want to talk about what the goals are and what we really want to communicate tonight. The first one is to describe how switching to single-payer healthcare would save the Commonwealth money so that you can walk away with an understanding of what is required to fund single-payer health insurance, and why it is exactly that single-payer is economically more efficient than the current system, which is not really a system at all. And so we'd like to describe how it would save money and outline what is necessary to fund single-payer. What are the most important things that the Commonwealth must achieve in order to make single-payer viable and a success. Just to note that in past years, as Lynn said, this analysis has been conducted by Dr. Friedman. He was unable to renew it this year, and so I built relying very heavily on the structure of his past analyses and the wording of his report. But I've used updated data, and I've updated methods in several key areas. So I just want to start with some of the main takeaways so that you can hold them in your mind throughout the rest of the presentation. And we'll be returning to these throughout. The first thing is that implementing single-payer healthcare unambiguously would save money for the Commonwealth. The bulk of that savings is contingent on the Commonwealth's ability to, one, negotiate lower prices, and that's in a number of different areas, which I'll talk about, and two, to reduce administrative costs on both the provider side and the insurance side. And kind of included there is also eliminating profits in the insurance industry altogether. If you don't have to pay for profits, that is reducing costs. But those are challenges that the Commonwealth the state of Massachusetts has to meet. And so we have to talk about how to do that. Another key takeaway is that additional healthcare costs beyond what the government is already spending will be paid through taxation instead of premiums, deductibles, copays, things you pay at the doctor's office. And that taxation plan, I show in the analysis that it is more than sufficient to fund single payer healthcare. Um, but it also puts the power in the hands of the people of the state to decide how they want to distribute the burden of payment. Under the plan that is proposed in the act, in which I've used in this analysis, everyone earning less than $500,000 a year would save money, and those savings would be much higher as a proportion of your income if you have lower income. And I'll talk about that in detail. Um, just a note on terminology. I'll talk about the trust, or occasionally I might write the MHCT, and that refers to the Massachusetts Healthcare Trust, which is set up in the act, in the bill, to administer single payer health insurance at the state level and manage the finances. And so, um, uh, what the negotiations that would be done, the distribution of resources will be done by the trust. This system will be similar to what we have right now as Medicare, but with broader coverage, which I'll talk about, and again with paid for through taxation without any premiums, copays, deductibles. Okay, an overview of the structure of the analysis, and which comes in three parts, and then we'll go into each of the three parts in order. I should also say that I think as questions come up, if you put them in the chat, John will curate them and ask them at the end. So be thinking as I'm talking about questions that you have. Okay, this overview, three main parts. The first is savings from eliminating unnecessary spending. And we think that we can eliminate about $55 billion in unnecessary spending. But the current system has a lot more problems than just unnecessary spending. We're not just spending too much on healthcare, we're spending too little in a lot of important areas. And so a lot of those savings have to go to improving the health insurance system. And that goes to both expanding coverage to uninsured and underinsured individuals, and also ensuring fair prices. And that looks like increasing Medicare and Medicaid prices, while also lowering private health, the prices that are currently paid by private health insurance. I will talk about that in detail. The third main part of the analysis is of that tax revenue that I mentioned. Okay. And all together, we end up with a $10.4 billion surplus. And I should say that is if it were to be applied in 2026, which it has not been. But that surplus only is projected to increase with time. Okay, so now going into each of these three parts in more detail. First, savings from eliminating unnecessary spending. First important number is the amount that we think that the state would spend on healthcare in 2026 under the current system. And that's about $126 billion. This is what that looks like over time. We can see that we are about here. And so we're at about a 400% increase in health expenditure relative to what we were paying in 2000. That is a huge increase. We can see the USA here is in yellow, and these are various estimates of Massachusetts spending over time, so you can compare. The estimate I show is this blue one. By implementing the single payer, we think we can save $55 billion by lowering prices and eliminating waste. And this is how that breaks down. We'll come back to this graph, but I want to describe it in more detail, where those savings come from. Of those savings, like I said, about 25 billion will go toward expanding coverage, and the remainder will return to the economy, which means that it will be spent on by consumers on something other than healthcare, or saved, invested. And so in total, the trust would spend about $98.7 billion in 2026 on healthcare. So you can see that's a savings of about $30 billion. Okay. those savings come from two main areas. One is, and this is that pie chart that I showed, which I'll show again. The first is negotiating lower prices, and that comes in three main categories: physician prices, hospital prices, and drug and also medical device prices. The second main category is lowering administrative costs, also another huge potential source of savings, and that comes from both provider administration uh, and insurance administration. And I kind of lump in profits with this. It's really non-benefit spending is how it's categorized. So breaking this down, first we're going to talk about negotiating lower prices. And the first category there is physician prices. Uh, we estimate that, or we use an estimate that shows that currently private health insurance prices, and you'll see I write that as PHI sometimes. Private health insurance prices for physician and clinical services are about 140% of Medicare prices. If the Commonwealth were able to negotiate physician prices down to Medicare prices, plus 10% of Medicare prices, we would save about $5.4 billion. And so you'll see this is going to be a common pattern. We're going to need to rely on the state to be able to negotiate prices down to some level. And where it is able to negotiate that level down to, on average, is dependent on how negotiations go in the negotiation power of the state. And so that's one thing to walk away from this presentation with is like a lot hinges on the ability of the state to negotiate. We think, and we used that estimate here, that a reasonable target price rate on average is Medicare prices plus 10%. I'll talk about that a bit more later, but basically that's to ensure fair prices. And so we not only increase Medicare prices plus 10%, we also increase all Medicaid prices to Medicare levels plus 10%. Okay. The second category is lowering hospital prices. Similar, these are more inflated using a more recent estimate from RAND, a think tank. And those are about 270% of Medicare prices. If we could lower these down to Medicare rates plus 10%, and this is one of the biggest categories of sources of savings total, we could save about $19 billion by lowering the prices paid charged by institutions as opposed to individual clinicians. The third category of savings from price reductions is drug prices, where we assume that private insurance pays Medicare Part D prices, which are about 300% of Medicaid prices. If the Commonwealth were able to negotiate drug prices down to Medicaid rates, that would be about $8.3 billion. One thing to note here is that that is a much lower number than the savings from hospital price reduction. So we talk a lot about really expensive drug prices. In the end, it's actually not one of the biggest. It is important, really important, but it's not one of the biggest categories of savings. If we were only able to negotiate prices down to the level that the VA pays, the Veterans Administration, and they pay about 35% more for drugs than Medicaid, then savings would be about, you can see down here at the bottom, about $7 billion. So that's not a huge difference. And we have a surplus. So this is what I talk about this is what I mean when I talk about thinking about the negotiating power of the state. We could negotiate down to Medicaid levels, which are very low, or we could negotiate down to VA levels, which are a bit higher. It makes sense to me that we could maybe negotiate down to VA levels because the VA represents a population of a comparable size to the state of Massachusetts. So they would have in like market terms a comparable negotiating power with drug companies as the state of Massachusetts. And so that's kind of the things to think about here when we're talking about these negotiations. This I think is not super important, but I put it up so we can come back to it if people are curious about counterfactuals. If we were not able to negotiate drug prices down to a certain level, how would that affect the surplus overall? And so I'll show this kind of graph in a few different ways. You see here's 2026. As I said, we see a $10.4 billion surplus in the end, which means that the state, uh, through the tax revenue plan that we have, is taking in $10.4 billion more than it is spending on healthcare. If we were only able to increase drug prices to VA levels without that, without the Medicaid increase, you see, uh, the dip here is not so much. So that's the kind of thing to take into account when we're thinking about these negotiations. Okay. The second big category of savings from eliminating unnecessary spending, we had first price reductions, and now we have reducing administrative costs. So that's the second big one. That, as I said, comes in two categories: provider administration and insurance administration. Um, so provider administration is uh, like the documentation done by providers while treating patients. Insurance administration is the actual like billing process. Um, and here the method that we use basically is to assume that provider administrative costs can be reduced to Canadian levels. And this is going to be really important. If a state isn't able to make the paperwork process more efficient than the current private system, then we're not going to be able to achieve these same savings. But Canada can do it. And so we think that Massachusetts can also do it. Uh, and the current system is so wildly inefficient, um, that we think these savings can be achieved. So the goal here is to reduce to these provider administrative costs to Canadian levels. If we're able to do that, we think we can save about $16 billion in provider administration. If you're curious, I won't do this in much detail, but this is kind of how it breaks down. So, for example, for hospital care, we see alternative estimates give about 20 to 26% of costs in hospitals are in provider administration in the US, whereas in Canada, it's about half that, about 13%. So this would be having the amount of money spent on administrative work in hospitals. Okay, the second category, as I said, is reducing insurance administrative costs. And here I'm also including eliminating profits by insurance companies. The key numbers here are that in 2026, we project that 11% of private insurance company expenditure will be what the Center for Medicare and Medicaid Services calls non-coverage expenses, which is basically money that is not spent on covering medical care. And so that is important stuff like administration. You're never going to be able to do without administration. But it can be reduced if the motive is not a profit motive, and profits will also be eliminated in this. And so traditional Medicare operates with what's called a medical loss ratio, which is effectively boils down to non-coverage expenses of about 2%. So, or 98% is the medical loss ratio, but non-coverage expenses being about 2%. And so private insurance companies spend about 11% on something other than covering medical care, whereas traditional Medicare spends about 2% of its money on covering something that is not medical care, so administration. So if we can reduce administrative costs to 2%, we would yield about $11 billion in savings just from this insurance administration cost reduction. So again, that's reducing the average rate of administrative costs from 11% to 2%, from private insurance levels to traditional Medicare levels. Okay, so that is that first big main category of eliminating unnecessary spending and the savings that we get from that. If we and that total, as I said in the early slides, is about $55 billion in savings. The main categories there being price reductions and administrative costs. Now, as I said at the beginning, the problem is not only that we're spending too much money, we're also not spending enough money in some key places. And so switching to single payer, or at least a good single payer model, would require some additional expenses. And it boils down to about $25 billion of additional expenses. Okay, what are those costs? What are those additional expenses that we have to pay? Those costs come from two main areas. The first is expanding coverage. Uh, that is giving coverage to uninsured individuals who don't currently have insurance, and also improving the coverage for underinsured individuals. Maybe you have medically necessary treatment that you need or a medication that you need, but your insurance won't cover. Then you have insurance, but you're underinsured. Okay, so first big category of additional costs is expanding coverage. Second big category of uh, of additional costs is increasing Medicare and Medicaid prices. And there's less nuance here. We're just raising the prices to 110% of what current Medicare prices. Okay, so going into that first category, expanding coverage, we'll first talk about the uninsured. And this is a relatively small expense of about $2 billion in the grand scheme of things. We just assume that the uninsured population will stay relatively steady as it has since about 2015 at just under 3%. Uh, if anything, it will be lower. Uh, we also assume that we use estimates from the literature to estimate to estimate how much the uninsured currently spend on healthcare, because if you don't have insurance, you're still spending on healthcare, but you're going to spend much less if it's not covered. We also, uninsured people tend to be healthier and younger. And so we assume they'll spend only about 80% as much on healthcare as currently insured individuals do if they were given insurance. And so that cost ends up being relatively small. A much larger cost is improving coverage to for underinsured individuals, and this comes out to over $10 billion, what it would cost to improve this coverage. A good question is like, how do you measure that? What does it mean to be underinsured? And I think this is worth going into a little bit so that people watching can understand how we're thinking about the kind of economic problems here when we give a bunch of people insurance. How does that affect the economy? How does that affect demand for healthcare? If you don't have insurance, then suddenly you do have insurance. You're much more likely to get to spend on healthcare. So that's called induced demand, which I'll mention. So we use here a measurement called actuarial value, which is just the percentage of healthcare costs that an insurance plan covers. Uh, if your insurance plan covers everything that you could possibly want in a hospital, including plastic surgery to make your nose look better, stuff like that, medically unnecessary things, you would have 100% actuarial value. We estimate that on average in Massachusetts, the current actuarial value is about 86%. Uh, Single payer would offer an actuarial value of 96%. So why not 100%? That remaining 4% would be medically unnecessary treatments. And that is an important thing to think about. What counts as medically unnecessary? That's one of the challenges that the state is going to face. But it would be defined more generously than many private insurance plans currently define it. And it also includes small out-of-pocket purchases like aspirin and Band-Aids and stuff. But we've talked about how those might dwindle over time, those out-of-pocket purchases. As I mentioned, increasing coverage also induces demand. What that means is if I give you health insurance, you're more likely to spend on healthcare. And so healthcare costs increase more uh, uh, than if we weren't to account for this induced demand. And we use estimates from work done on the ACA to to estimate that, to calculate that, increasing the actuarial value on average from 86% to 96% would increase utilization, increase demand for healthcare by about 8%, 7.6%. And so that is some additional cost that we have to consider. Is we give everybody health insurance, they're going to go out and they're going to go out and spend on healthcare. Or demand healthcare, which the state now is paying for. I can come back to this if you're curious. This is just how that breaks down that calculation of current actuarial value in Massachusetts. Okay, so that's expanding coverage. Now that's the second category of additional costs are increasing Medicare and Medicaid prices. This is less complicated, but it is important. We assume that the Commonwealth can negotiate hospital and physician prices to, on average, 110% of Medicare levels, as I mentioned. Possibly hospitals and physicians put up a lot of resistance, and we can only negotiate that down to 120% of Medicare levels or 115%. And so I offer in my report, alternative estimates for if we were only able to negotiate it down to this level, how would that affect the financing? So raising Medicare, Medicaid prices costs about $11 billion. That is a big expense. But Medicaid currently underpays hospitals and physicians, so this is to ensure fair pricing. And we also have some additional expenditures of about $2 billion. One really important thing here, and one major question that we get asked when we're talking about implementing single payer and reducing prices is, okay, you're cutting the prices going to providers. Isn't that going to endanger community health centers? Isn't that going to put small community health centers out of business if you're cutting prices, if they're getting less money coming in? Well, community health centers, which disproportionately help disadvantaged individuals, are providers that rely most heavily on Medicare and Medicaid prices and least heavily on private health insurance. And so this is something that hospitals think about a lot, is the proper mix between private health insurance income and Medicare, Medicaid income. And for community health centers, so FQHCs, federally qualified health centers, for example, get only about 10% of income from private health insurance. And they, because of these increase in Medicaid and Medicare prices, would actually see an increase in revenue, even though private health insurance prices are being decreased. So I'll say that again. The small community health centers that serve the most disadvantaged individuals will actually benefit from implementation of single payer because we plan to increase Medicare and Medicaid prices, even though we are cutting private health insurance prices, because these community health centers rely much more heavily on Medicare and Medicaid than they do on on private health insurance. Whereas big hospitals that serve more privileged patients rely much more heavily on private health insurance and will see a reduction in revenue. So that's important. Okay, that is that second big category of additional costs. So we had the $55 billion in savings, and then about $25 billion of additional costs to improve healthcare in Massachusetts. So we have all that savings, but there are deficiencies. We need to spend more. And this is an example of what I talked about of what would the surplus be that the state ends up with if we are only able to negotiate prices down to Medicaid levels plus 20% or plus 15% instead of the target rate on average of Medicare levels plus 10%. And we see even if we can only negotiate them down to Medicare levels plus 20%, so we can't get them all the way down to plus 10%, we're still in the red and the surplus still increases over time. Sorry, we're still in the green. We're not in the red. And the surplus increases over time. And so that's that orange bar here is like the worst case scenario of only being able to negotiate it down to 20%. Of course, it could be worse. But you see kind of the progression here of this is 5% increments. And again, surplus only increases over time and we're in the green. Okay, the third main section of the analysis. So we talked about savings, we talked about additional costs, and now we have to talk about tax revenue. Because under single payer, you would no longer have any premiums, any copays, any deductibles. All healthcare spending would be paid through taxation, which gives the people of Massachusetts a lot of power to decide how healthcare is paid for. Whereas in a private system, individuals, voters, are completely disempowered to decide how healthcare is paid for. They just have to uh, choose the plan that fits them best, which is often the cheapest plan and has lower actuarial value, which we talked about, the percentage of costs covered. Okay, so what is actually required to fund single payer? Well, as I mentioned at the beginning, with that $55 billion of savings and then plus back that $25 billion of of additional expenditure, we're still spending about $100 billion on healthcare. That's a lot of money, and we need to get that money from somewhere. Now, we do have about $63 billion in existing revenue. So that is, for example, federal money coming in for Medicare and Medicaid, or for Medicaid, um, which is endangered and because of the current federal administration. Um, and so that's something we need to think about. But okay, and so that's existing revenue. Uh, and I'll break that down in a second. Uh, However, 63 to 98 is still a gap there that we need to cover. And the bill, as proposed, would implement five taxes. And I'll go through them right now. And those taxes in total, I estimate, would raise about $46 billion in new revenue. That's about, okay. And so what are those five taxes? Well, it's a 7.5% tax. And these are payroll taxes. I should have put that in here. 7.5% tax on the payroll of small employers, an 8% tax on the payroll of large employers. Okay, that is employers with more than 100 employees. That's the difference. A 2.5% tax on the income of employees, a 10% tax on the income of self-employed people, and finally, a 10% tax on non-payroll income. So that's things like capital gains, investment income. And this altogether leaves the trust with a $10.4 billion surplus in 2026. I mean, it would if it were implemented this year, and it only increases over time, our estimate. So those are the five taxes. There's not that much to talk about here. I can, this is what the bill proposes. And these are my estimates for what that would raise. Oh, I should also mention that each of those taxes has a $20,000 exemption. So the first $20,000 of income is not taxed at all. So if your income is less than 20,000, there's no tax here. And we play around with alternative methods of exempting there, and we get alternative surplus estimates. So this is again that kind of counterfactual analysis, which I can come back to if you're curious about it. Okay, the only thing left I want to do is just break down what is that existing revenue, that $63 billion that I talked about. And the reason this is important is because this assumes that we're continuing to receive current levels of federal funds, which honestly we're not, given the current federal administration. Um, and this is how that breaks down. Uh, and so, for example, we've heard a lot of talk recently about ACA subsidies. ACA subsidies being the reason the government was shut down in the fall. And my analysis assumes that we're getting historic levels of ACA subsidies. But for example, the OB3, the One Big Beautiful Bill, takes away about $3.5 billion of existing revenue annually from the state of Massachusetts, which is not accounted for in the report. So if you want to consider that, which is worth doing, take that $10.4 billion surplus and subtract $3.5 billion from it. That is the effect of that One Big Beautiful Bill. Reductions in primarily Medicaid here. So that's these $22 billion coming in. You can take $3.5 billion away from that in the existing revenue. And I could talk more about that. It is an important thing to consider. Yeah. Yeah, and just this remaining out-of-pocket spending that's on Band-Aids and aspirin and stuff like that. maybe will dwindle over time. Okay, this is a really important figure. This is the percentage of income that you would save by paying for healthcare through taxes instead of through premiums, copays, deductibles, and private health insurance. And how it works is that here on the x-axis you can find your income, and so this is less than 15,000. This is between 15 and 30,000, between 30 and 40, between 40 and 50, etc. And on the y-axis, the vertical axis, is the percentage of your current income that you would save, you would be able to spend on something other than healthcare, so on housing or put it in, save it for retirement, um, uh, by switching to single payer. And so if you make less than $15,000, you see that you save about 35% of your income that you would spend on healthcare, you no longer spend on healthcare. And actually, you're paying no money at all for healthcare because you make less than that $20,000 exemption. If you make $70,000, you will see about 8% of your income that you would otherwise spend on healthcare, you would no longer spend on healthcare. You will pay more taxes, but you will save money by paying for healthcare through taxes instead of in the current system. And we see only at above 500,000 do you start paying more for healthcare under single payer than you do in the current system. So that's individuals earning more than $500,000 a year are paying would be paying more for healthcare under single payer than in the current system, but everybody earning less than $500,000 would be saving. Another way of looking at this is that currently you are paying a lot more for healthcare than you need to if you're earning less than $500,000 because of inefficiencies and profit in the system. Okay, and that kind of wraps up that third category of tax revenue. And so just to summarize here, and this is, I think, my last slide, under the current system, we estimate in 2026, we'll spend about $126 billion on healthcare. Switching to single payer would save about 55 billion, but we don't only spend too much money, we also spend not enough money in certain important areas. And so we have to spend an additional $25 billion to increase coverage and also increase Medicare and Medicaid prices to a fair level. And with our existing revenue plus new tax revenue, we would have a $10.4 billion surplus in 2026. And oh yeah, and this is just the last graph that shows the increase in the surplus over time. This red line dipping down here is a worst case scenario estimate that assumes that assumes unrealistic is an unrealistic assumption in my opinion in terms of the increase over time in private hospital, physician, and drug prices relative to Medicare levels. And I think that any of these three estimates, the yellow, blue, or purple, are the realistic estimates which show the surplus increasing over time. And those are the estimates we used in graphs like the ones I showed before that show the surplus under different counterfactuals. And that's all I have. So please put questions in the chat and John will curate them and ask them to me, and I'm happy to answer any of them. I'm happy to go back to any slide that we've talked about. I'm happy to talk about counterfactuals. I will say that my analysis was limited to what is proposed in the current version of the bill, plus some of those counterfactuals around negotiations, stuff like that. And yeah, so those are the limits of the analysis. But I hope that was helpful, that you were able to take away from that. Any sources that I didn't put those in the slides, but they should be in the report. If you have any questions after this that can't be answered in the report, please reach out to us, please email. And yeah, that's what I have.
That's excellent. Thank you so much. That was a great presentation. Really walked us through the numbers to see where they're coming from and what we're going to wind up with. We really appreciate that thoughtful and depth analysis on this important issue. And I just want to take a minute to MassCare and the Universal Healthcare Education Fund. Would also like to thank the Hilltown Medicare for All Advocacy Group along with other donors for funding this study. And I want to thank everyone for joining us for this presentation.